respiratory module එක කරන කාලේ first line is this a severe asthma? Is this a I mean, this is a very mild, sort of mild intermittent kind of asthma, isn't it? So, for such a patient, what were you all taught as the initial treatment? As needed salbutamol. I assume this is what was taught in respiratory module. Was it changed, or did you all hear anything new afterwards?
The MART therapy, sir.
The ඒක ඔයගලන්ට කොහේ හරි උගන්වලා තියෙනවද?
It was taught during the asthma lecture in therapeutics, sir.
Right. Okay. So I would think that is how you should look at it, because the GINA guidelines tend to update every year, and I think, if I'm not mistaken, in 2022, if not at least this year, this concept of MART therapy came up. Essentially, the idea is, in several studies, they have shown giving inhaled corticosteroids, even for mild intermittent asthma, okay, at least on PRN basis, will prevent exacerbations and hospitalizations. Okay, so yes, you can give X LABA X based therapy as the first line treatment, even for mild intermittent asthma. So that's the first point. Second point is, there are no X and salbutamol or X-SABA combinations. But we do have X-LABA combinations, and among LABAs, formoterol has a quick onset of action, and it is as quick and effective as salbutamol in relieving symptoms, so as reliever therapy. Okay, so based on these 2 points, you will have to look for an answer which has PRN basis, because the symptoms are infrequent. So all 5 answers are PRN or as needed. Then you have to look for an answer with an X or inhaled corticosteroid. So E goes out. Then we have to find a combined LABA, which is formoterol, and that leaves you with the option of B. Okay. Now, theoretically speaking, answer D is not wrong, because you can give X plus SABA, but then this will be 2 inhalers, and whenever the patient is using a SABA, he will have to take the beclomethasone inhaler as well. Okay, right. So for practical purposes, therefore, possibly the best option would be budesonide formoterol combination. Okay, any questions? So this is a transition phase in guidelines. So they still retain the old approach of SABA-based treatment, okay, where they say take X whenever SABA is taken, then low dose maintenance X, whereas the preferred pathway is as needed low dose X with formoterol. So we could probably stick to that answer. Okay. So how do you decide if a patient is diagnosed with asthma as a new diagnosis, where will you start? Any idea? Step 1, 2, or 3, 4, or 5? I suppose this would have been touched upon in therapeutic lectures, but generally, what I understand is if the symptoms are severe enough, in other words, 4 to 5 days a week of symptoms, or waking up with symptoms at least once a week, then you start at step 3, which is a maintenance plus PRN reliever. If it is milder, like in the patient described here, you start with step 1, 2, which is a combined step. Then if it is worse, so then we call it uncontrolled asthma, or if lung functions are already poor or presenting as an exacerbation, then you start at step 4 and then step down. So Kirtikan, you are correct. So this is how severity would guide the starting point. Okay. I think that should be fine. Unless there are any other questions, we'll move on to the 28th. Right. 62-year-old male with a history of smoking 40-pack years presents with dyspnea and is suspected to have COPD. Which of the following would indicate an alternative diagnosis? Right. So which of these are, in other words, which of these are not compatible with the diagnosis of COPD? Chronic cough, හරිනේ නේද? Episodic nocturnal wheeze, හරිද? Is that true? Generally, we tend to say COPD is more persistent or daily symptoms, whereas asthma is intermittent symptoms or good days and bad days. So this is not really fully compatible with COPD. Exertional dyspnea, yes, both with asthma and COPD. Frequent episodes of bronchitis, again, a part of COPD diagnosis, bronchitis plus emphysema. Regular sputum production. Now, this is a bit tricky, but generally what we say is COPD has a dry cough or cough with scanty sputum. Right? This doesn't say copious sputum or large volumes of sputum, which is the case with bronchiectasis. So I think this is fair enough as a feature of COPD. So regular sputum production is fine. What happens during an exacerbation is sputum volume, thickness increases, sputum becomes more voluminous, more thick, and it will also change its color. Otherwise, it's a chronic cough with scanty or little amounts of sputum, but this is regular. So I would settle with the answer B, episodic nocturnal wheeze. Any alternative thoughts? Okay. Next question. 66-year-old male presented with a 2-month history of chronic cough. Which of the following pairs of clinical features is most suggestive of bronchial carcinoma? Hi. Clubbing and basal crackers. Clubbing, you know, the cancer, lung cancer? Yes, so that's true. Bibasal crackers, you know. No. Bibasal crackers, you know, we would think of interstitial lung disease or heart failure or something like that. Okay, so that A is out. Cigarette smoking, yes, it's a risk factor. Bilateral bronchi. Bilateral bronchi, bilateral bronchi, it's more obstructive airway disease, something like asthma, COPD, or bronchiectasis. Cigarette smoking is a risk factor for COPD and even for asthma, yes. So, can carcinoma, bronchial cancer, cause wheezing or bronchi? Yes, it can, but it is more localized and monophonic. So if the cancer is obstructing an airway partly, that can give rise to a wheeze. But it's the same consistent airway obstruction, so the frequency of the wheeze is the same. In contrast, with asthma COPD, it's more diffuse small airway obstruction to varying degrees, so it's a bilateral diffuse polyphonic wheeze. Loss of weight and left lower lobe dullness. So loss of weight is a feature of lung cancer. Left lower lobe dullness, that can happen, can't it? Either due to mass effect or otherwise. How can a lung cancer cause dullness?
So pleural effusion.
Yes, very good. If there is a lower zone dullness, it could very well be a pleural effusion. Okay. Why would lung cancer cause pleural effusion? It's most often due to metastasis into pleura. Okay. Any other cause for dullness? So mass effect, if there's a large enough mass, yes, it can. Pleural effusion, yes. Anything else? There is a lobar collapse that can also cause a dullness. So if the mass is large enough to block the airway, it will collapse the lung. Okay. Pleuritic chest pain with an area of bronchial breathing. This is more suggestive of what? Pleuritic chest pain
Pneumonia.
with,
Pneumonia.
yeah, exactly. This sounds more like a lobar pneumonia. Okay. Production of copious sputum and clubbing is what?
Bronchiectasis.
Yes, bronchiectasis. Very good. Lazy. There. Any questions? No questions. 56-year-old female presented with pruritus for 2 years. Other than that, she was asymptomatic and had no past medical history and was not on any routine drugs. Examination showed xanthelasma and scratch marks were observed. WBC, HB, sodium, potassium, creatinine, all are normal. LDAC mild increase. IgM positive, I suppose what they mean is IgM is increased. ANA is negative. Bilirubins are high. Upper limit is usually around 21. Alkaline phosphatase is clearly high. INR is high. Albumin is low. Total cholesterol is high. Upper limit is, let's say, 200 or 240. Ultrasound shows chronic liver cell disease or changes of cirrhosis. Then the question is, what's the most probable cause for her pruritus? Okay. Autoimmune hepatitis, hepatitis B, NASH, PBC, sclerosing cholangitis. What's the answer? Hello. Right. So one possibility is C. Okay. D. Any other answers? Another one for D. Right. Now, okay, more and more answers for D. All right. Good. Now, This is the classic story of PBC, primary biliary cirrhosis. Classic story of PBC, remember this very well, is a middle-aged female presenting with long-standing fatigue and pruritus. So, pruritus comes before jaundice. What's the cause for pruritus? What substance is causing pruritus?
Bile salts.
Very good. Bile salts. Bile salts කියන්නේ මොකද්ද? Cholesterol breakdown වල හැදෙන එක. And what causes jaundice? That's bilirubin. That's the product of heme breakdown, hemoglobin breakdown. Very good. එතකොට මේ PBC එකේ characteristic feature එක තමයි they get pruritus and fatigue long before they get jaundice. Okay? And biochemically ගත්තාම initial stages වල only abnormality is isolated increase in alkaline phosphatase. Okay? Now this patient unfortunately seems to have progressed to develop cirrhosis. Now why do I say he has progressed to develop cirrhosis? Because ultrasound shows features of cirrhosis and the albumin level is very low. Okay. Now, apart from the clinical history of pruritus and being a middle-aged female, what are the other telltale features of primary biliary cirrhosis that you see here? That's the very high cholesterol with xanthelasma. That's the very high cholesterol with xanthelasma. Okay. Go to take a shot. Give me a couple of minutes, please. Hari, sorry, Lamai. Okay. Now, so what are the other features pointing towards PBC?
So raised IgM.
Hari, very good. So raised IgM is characteristic feature of PBC. Don't ask me why. That's how it is. And if someone wanted to do any other blood test, what can be done? Any antibody? Another anti-mitochondrial antibody. Name. Okay. This is a comparison of common autoimmune liver problems. Have a look at this. So autoimmune hepatitis, PBC and PSC, you need to know to some extent about these three things. So PBC, as we said, middle-aged female, they are all associated with some other autoimmune disease. So PBC is characteristically associated with Hashimoto's, Sjogren's, limited cutaneous systemic sclerosis, and rheumatoid. There are quite a lot, but just try and remember these things if they ask in a true or false question. If you know it, you mark it. If you don't know it, leave it because there are so many associations. So as I said, the predominant presentation is fatigue and pruritus. Later in the disease, jaundice and xanthelasma will come up. Investigations, high ALP. ALT's liver enzymes are risen only mildly, but there are very high cholesterol level. Then high IgM and antimitochondrial antibody. අනේ ළමයි මේ මම මේක ඉතුරු ටික හෙට කරන්නද?
Hello sir.
කමක් නැහැ.
අවුලක් නැහැ sir.
sorry අනේ.
මේ හෙට sir එතන වෙලාවක් එහෙම
6-8 වගේ කරමුද?
හරි sir. හරි. මම අමන්තට කියන link එක එවන්න.
හරි. okay.
හරි sir. Thank you sir.
Thank you, sir.
Okay, sir.